Continuing on with our theme of wellness, we are now very fortunate to have a panel of medical experts whose vocation is to help aviators obtain and maintain their medical certificates. Here to moderate this panel is ALPA's Aeromedical Chair, First Officer L. Brinks. Good to see you again. I missed you. Hi, good morning, good morning. Hi, good morning.
We're going to be doing the Meet the Doctors panel, and for those of you, if this is your first time attending the Air Safety Forum, this is normally one of our most requested panelists because, well, everybody wants to know what's going on in the medical world, even though we may not speak the medical jargon, and how does this how is this implemented in our lives, and how does this affect our medicals? So, my name is Ellen Brinks. I'm a Delta Airlines A330 pilot, and with me, I have some excellent resources and leaders within our regulators and within our support for ALPA is Dr. Susan Northrup. She is the Federal Air Surgeon for the FAA. Dr. Tyler Brooks, the Director of Medicine for Transport Canada, was able to make it this year. I'm so excited to have you. And then we have Dr. Quay Snyder, our AMAS, Aviation Medicine Advisory Service, and our ALPA Aeromedical Office, President and CEO. So thank you all for being here, doctors. I do appreciate it. And with that, I won't read the entire bio because they're extensive, and we were determining that Quay was graduating med school before I was even born. But they do have extensive bios in the agenda or in the app. So, we'll get started with the questions, and I am going to try to leave about 10 minutes for questions or so at the end. So I'm sure that there will be a few that come up, but we'll get started. So, Dr. Northrup, if you could tell us about within the FAA, we have started trying to change some of the testing that is required and for your medical to, let's say that a pilot has a heart attack or cardiac event. Some of the tests and where special issuance would be required, some of the doctors that we see in our actual out practicing medicine and the treating physicians, they're saying that some of the tests that are required by the FAA are not actually medically necessary anymore, or they're a danger to the pilot's health, such as an angiogram post-cardiac. So could you talk to us about how you change the policies for special issuances? How do you determine what a special issuance should require for what tests, things of that nature, and how do you keep up with the changes in medicine? Because as medicine moves at the speed of light, there are new medications coming out every day, and there's new tests that are coming out. So how do you use that and to be able to issue safely a medical for a pilot? So.
That's a lot of questions.
I know, there's a lot, so we're going to start there. So.
All right, so let me actually take you all on a bit of a journey. I have been in place as the Federal Air Surgeon since January of 2021. I had been the acting deputy Federal Air Surgeon for a month or so prior to that. And one of the things we did in the Office of Aerospace Medicine was we held an aeromedical summit. And in this summit, we invited people from the industry, people from bargaining units, like ALPA, people from pilot advocacy groups like AOPA and EAA, and anybody else we could think of. We did leave a few groups out, which we are going to rectify the next time we do this. And what we did, essentially for the first day, is for any scouts in the organization that are here are going to recognize roses, thorns, and buds. We asked our people, the folks we serve, to tell us what we're doing well, what we're not doing so well, and what we need to consider doing. Out of that summit, we took 15 items, and we put them on a near-term, a medium-term, and a far-term dream sort of thing. And one of those was how we look at what's required for individual diagnoses. Now, in order to unpeel that onion, you've got to look at a whole bunch of other things. Like, what's the current science? Like, what's our current guidance say? Like, how do we implement this? So one of the things that's important to remember that there's a huge difference between what's medically necessary for someone that functions in 2 dimensions from someone that functions in 3. Because the minute you introduce altitude and some of the other stresses of being a pilot or in the aviation industry, and the responsibility to contribute to safety, what's required gets a little more interesting. Now, laying that groundwork, there's some other things we did too, like how many of you gotten love notes? I'm sorry, I shouldn't call them that. Letters for information from us. If you notice in the last 2 years, we've changed those so that we don't do stress tests by reading the first 2 paragraphs, all the legalese, and then we tell you at the bottom of paragraph 2. Yeah, we switched that all up. So we tell people a lot sooner what we did. All the legal stuff is there because there are more lawyers at the FAA than there are doctors. That's the way I live. Yeah, okay. So, SRM, SMS. How do you apply current science in a risk-based system when it comes to humans that aren't linear necessarily? And we're doing that. So we look at what's the minimum we need to have in order to arrive at an aeromedically astute decision. Some of the things we've done recently, like many of you have heard about our SSRI, selective serotonin reuptake inhibitor, antidepressant, also used to treat anxiety and a few other conditions. And we initially rolled that out in 2010. It's been a minute. And you could be on only 4 of these medications. And you had to wait a year. It used to be a year. And then every year you had to get repeat studies, right? You had to go get neuropsych testing. After a couple of years, we reduced it to 6 months. And then when I got on board, and I've been in the seat for about a year, I looked at my psychiatry branch and said, so, tell me the value of the neuropsych testing, which runs $2,000 to $4,000. And we're doing this every year. They reviewed 452 cases and determined that in those individuals, in the absence of clinical findings, the neuropsych testing did not change the decision. So we got rid of it. So anybody in your groups that's in the SSRI program, we just save them between $2,000 and $4,000 a year on something that may not be clinically indicated, occupationally indicated, yes, but maybe not clinically, and we took that off the table. So the last thing I've tasked myself, and I don't have a final answer for this because they're still doing the research for me, is why do we still require post-event catheterization for pilots that have had stents or bypass? You go back 20 years ago, there was a real strong indication, but they're doing the research for me. I can't tell you we're going to get rid of it, so please don't quote me. But we are actively looking to see if we can modify what we do for the individuals who have had heart attacks or coronary artery intervention. And we're doing that across the board. So, give you a little look underneath the curtain. We had lots of different documents that we used when we did aeromedical determinations. We now have one. And it feeds into the Guide for Aviation Medical Examiners. I don't like plain. I have a secret with the pilot group. I want to be transparent as far as I can be, with the understanding that there's still an art to medicine as much as we're trying to apply risk-based science.
That's amazing. Thank you.
So.
Thank you. No, you bring up very valid points too, because we have truly you've tried to move forward. You're accepting of our suggestions. You look at the science behind it, and that's what we need. So
We're a partnership.
yeah, absolutely.
I mean, I feel we have to listen to the people that we serve. So.
No, it's been wonderful. Thank you. Working with you. So, but there you go. So, Dr. Brooks, now following up on that, could you tell us how Transport Canada, what happens for your requirements? Because a lot of our pilots don't really know what, if, there's a form that they can go and look at online, but how often is the information updated? How do you make those requirements and changes for a pilot's medical in Canada? Because some of our pilots just don't have any idea. So could you explain a little bit about that?
Sure, no problem. It's a pleasure to be here. First of all, thanks very much, and it's good to see
Absolutely.
our colleagues here today. So our approach is much like the FAA's. Our goal is to establish the minimum requirements, the minimum information requirements in order to make a good aeromedical decision. And as Susan said, that doesn't always match with what is medically necessary. So we do have a specialist board, so practicing medical subspecialists who also have aerospace medicine experience that provide us with expertise and recommendations on what we need to do to manage cases. And when we're talking about complex medical cases particularly, we're practicing individualized assessment. So each case is really being assessed on its own merits. So in terms of pilots understanding what it is that they need to do, there's really two aspects to that. In the first case, we do have an existing handbook, which is targeted towards our medical examiners, but of course it's open source so anybody can look at it, and that is the intent. We understand that there are multiple audiences for these documents. So that's one source, and I will also add that since I came to Transport Canada about 5 years ago, my first role before becoming the director was actually looking at these policies and renewing them, modernizing them so that they would be accessible to everybody. They would be up to date as much as we can. As Susan said, and as you mentioned, things are moving very rapidly, but if we can provide the basis for understanding what is necessary, that's the goal, recognizing that things become individualized. So right now we are in a process of actually deconstructing the handbook. The handbook approach was sort of the old way we think of doing it. We're doing it more in a sort of modularized way now, which reflects what a lot of the other regulators are doing. So they're topic specific. They are using a departmentally standardized format. They're easier to sift through with the way they're set up with indexing and that sort of thing. And we're more agile then in updating those documents. So we're in the process right now of deconstructing the handbook and updating each of those policy sections so that it's more clear, and so that they're also in a standard format so people can find the requirements and the information that they're looking for. So that's the first piece. The second piece is getting back to the individualized requirement. That's a little trickier. It's very difficult to publish something that will cover all circumstances. So at the end of the day, complex files will be assessed on their own merits, and there will be individualized requirements. It's not going to be possible to publish everything that covers all instances. And we also have geographic differences to think about. Much like the United States, we're a very large country, and in some places we have to consider the impact that our regulatory requirements are going to have on patient care, because at the end of the day we're competing for medical resources, scarce medical resources, in order to achieve our aims. But ethically we have to think about, well, how does this affect people who are sick and need investigations or doctor time with a specialist. So we have to think about what's the cost of this, both to the individual and to the system. How available is a particular test? Is it reasonable to ask for it in this jurisdiction when people are in remote or northern locations, for instance? How sensitive is it? How specific is it? Does it give us the information we need at the end of the day? So on the one hand, we are revitalizing our entire policy set, but we also have these individualized elements at play. And in the end, we hope to hit sort of the 80 or 90% solution for most things in our policy set, but there will still be a small percentage of things that have to be individualized, and that's when people get letters from us, and we'll explain what's needed, and we can negotiate. So we will interact with the applicant and their local CAMIs to determine what's possible for that particular circumstance. That's it in a bit of a nutshell. I hope that helps.
Well, and I think for pilots, it's very hard because for us, we operate in a very black and white environment. And this is very gray because every person has an individual circumstance. So it's very, you have to be able to write a broad policy, but make it so that it's specialized or specific enough to actually cover individuals as well. So it's difficult and a challenge. So with that being said, we talked about some of the special issuance cases and how there's complex medical cases. Dr. Snyder, could you tell us a little bit about how AMAS helps with the compilation of some of these cases, because sometimes, I mean, some of the case files that you will submit to the FAA are 4,000 plus pages. Most of us just see one little medical certificate and that's it. And they don't understand all the background, the background of documents, and they can't figure out, well, why is this one test needed now still? So could you explain a little bit how you go about getting that? Does your office actually work on getting those tests? How does this work with the relationship with the pilot that might need a special issuance?
Sure, I appreciate that. Susan and Tyler both hit key points in this. The Guide to Aviation Medical Examiners has a number of protocols that pilots can follow. It's open source, and if they follow that and it's a routine problem, it's very straightforward. Many times the pilots, and unfortunately sometimes their AMEs, haven't looked at those documents and may not know what's going on. So our goal is to make sure that all of the appropriate aeromedical information is available to the FAA so that they can touch that package one time, reduce their workload, and reduce the timeline that the pilots are waiting for medical certification if they don't have that. And the way we do that is by interacting with the pilot about what tests may be required, interacting with their primary care physician or their treating physician if, like Susan and Tyler have both said, something may not be medically indicated, but it's aeromedically indicated, so that a safe decision can be made. And we can interact with that physician to let him or her know that, yes, in the interest of public safety and certification, we need that. Then we receive all the records from the pilots. They will send those to us, and we can go through those and say, these documents seem to be adequate, or sometimes we're missing this piece of document, or when we're reviewing the documents, oh, another aeromedically significant issue has come up. And this needs to be addressed before we submit it for review by the FAA or Transport Canada. And in doing that, then what we can do again is reduce the time that the pilot has to wait, reduce the anxiety, knowing that a complete package, reduce the workload on the Civil Aviation Authority, so that they only have to do it one time. There's not this exchange of information. And their physicians have all the documents ordered in a way that they need with a summary from us, just like we did in the military, outlining the key points and what we think would be an appropriate certification decision, or sometimes we're just not sure, and we'll go and say, please make your determination. And then if the determination doesn't come back with a clearance immediately, a special issuance immediately, then we can interact on behalf of the pilot and the pilot's physician to get the additional documentation that may be required so that a favorable decision can be made. And then occasionally we just need to tell the pilot that this condition that you have may not be compatible with flying in the long term. And rather than them wasting time and resources, we can assist them with getting all of the entitlements that they deserve, they have, so that we can maintain their stream of income, or at least maximize that without wasting their time and money, and in some cases, futile hope.
Yeah.
But that's really very rare.
Yeah. No, it is. It really, what's the full-on denial rate within the FAA?
Oh, you want my numbers?
No, well, if you care to share off the top of your head, yeah.
Okay, so let me begin by saying there is a whole generation of people that have heard the call that we're short on pilots. It's amazing. So prior to COVID, which made some undulations in the numbers, we had on average 385,000 applications a year for airman medical. Now those are not individuals, right? Because if you're over the age of 40, you got to make 2 for first class. But 385,000. Last year, it was over 416,000. So a rise of 30,000, most of them young people under the age of 30, first class medicals. So they're coming. How many of them get through the process and become ATP, that remains to be seen, but there are a bunch of them. So in the US, on average, 10% end up under special issuance of some sort. 94.5 of individuals that walk into an AME's office will walk out with a certificate. Now, it's not great if you're the 1 in 20. I get that. About 1% end up in initial denial, so 3,500 to 4,000. Most of those failure to provide. They just don't give us what we ask for. For final denials, once we've received everything, it's less than 0.2%.
So you have a chance.
Yeah, mental health diagnoses are a little higher, but taken across the board, it's actually really rare that we final deny somebody.
Yeah. It might be a process, but
It
yes.
might be a process, might
Yes.
take a minute.
So, yes. So I'd like to switch gears a little bit because I know that the age 67 debate is a hot topic within the United States. And what pilots may not know is that Canada does not have a retirement age. So Tyler, could you tell us a little bit about how Transport Canada came up with the no retirement age? Was it actually a decision made by Transport Canada to not have a pilot retire? And in that case, how do you go with the medical certification process for pilots that are, how do you deem them medically fit to fly an aircraft now?
That's a great question, and it's there are some legal elements to that I'm not a lawyer, not qualified to speak about. So I'll start with the kind of the things that I can say with certainty. So there is no age limit in our regulations for the issuance of what we call a Category 1 medical certificate or a Category 2. So Category 1 is for commercial professional aviation. Category 2 is for controlling. So there is nothing in regulation that restricts the age at which that can be issued. The bottom line is if you can meet the medical standards, you can be issued these certificates. As you get older, the renewal period becomes shorter, but you can still receive an issuance. So there's nothing in the federal regulations that defines an upper limit. It really comes down to the threshold of aeromedical risk that's acceptable. Mm-hmm. And as people get older, we tend in general to accumulate medical issues, and in time you may eventually hit that threshold where you can't meet the medical certification standards anymore, but it's not defined by age as such. Now, to say there's no retirement age in Canada, that's a little bit more of a nuanced discussion. From the federal side, to my knowledge, there hasn't ever been anything in the regulations that's defined an upper age limit. And I've asked everybody in my organization that I can think of, people who've been around for 25 and 30 years, and there's no, that goes way beyond corporate memory. So for all intents and purposes, there really hasn't been one. What's different, though, out in the environment is that industry, corporations can negotiate as part of their collective agreements with labor groups, with pilot unions and so forth. They can negotiate within their collective agreements a retirement age, and that's completely outside of the federal purview. We're not involved in that conversation. And there are other complexities as well. We have the Canadian Human Rights Act, and we have the Charter of Rights and Freedoms, which defines age as a prohibited grounds for discrimination, but there are also little exemptions and so forth. So bona fide occupational requirements can sometimes be used to define things like retirement age. But that's more at the industry level, and it comes down to collective agreements between management and labor at the industry level. But there's nothing at the federal level that defines that, which has been interesting because lately we've had discussions with. As you have alluded to in your question, there have been discussions internationally about what ICAO has defined as the recommended best practice for retirement age in the commercial sphere, and also other regulators have been looking at that as well for a variety of reasons. But that's where Canada stands, and the origins of it really are just there. As far as I can tell, there actually has never been one defined at the federal level.
All right, well, excellent. So, Susan, for you then, with that, granted, what could happen, we don't know right now, but if there's legislation that says that they have to raise the retirement and pilot age till 67, how would that affect our medical certification within ICAO standards? How would it affect it within the US? Could you talk about what possible changes we could see?
This is going to be terribly unsatisfying. No. But essentially where we are is we're waiting for the rest of the language in the reauthorization bill. We've seen what the House passed, and it had wide bipartisan support. We haven't seen, because Senate hasn't passed it, what they're going to have, and of course that has to go to committee and be deconflicted. And once that's happened, I'll be able to rationally talk about what might happen next. So sorry, don't know.
Your crystal ball is broken?
Yes.
Exactly. No, so then I guess, Quay, for you, have there been any studies or papers written recently or in the past that can document where do we stand as a pilot group? Is there anything specifically written for pilots about our cognitive skills, our health issues, what subtle or sudden incapacitation? Because I mean, we are it's an SMS system, and we're looking at a 1% safety margin. So could you talk about that a little bit? Is there anything out there?
Sure, there's some things out there, perhaps not specific to Part 121 operations, but the Naval Aerospace Medicine Institute studied a long time ago, 2 decades ago, cognitive function with aged cohorts. And there's a steady decline in cognitive function as we get older, but there's also a wider variability in each age cohort and their cognitive abilities depending on their condition. So a top performing 65-year-old pilot would have the cognitive abilities, not the flying skills, but the cognitive abilities similar to an average 25-year-old. However, the lower performing older pilots will be substantially below their younger cohort. The European Union, EASA commissioned a study that looked at the 1% rule that you're talking about. Ideally, aircraft, when there's a failure component, it's 1 × 10⁻⁷ and we try to project the same thing with pilots in redundancy. So the study came out looking at both single pilot operations, which are common in Europe, particularly the helicopters going out to the shore, single pilot commercial operations, and then dual pilot. And what they looked at specifically was the risk of sudden incapacitation. What's important was not what was studied, or that gradual or subtle incapacitation was not included in that study. But their conclusions of that, which was published in 2018, was that the threshold for that 1% seemed to be reached for single pilot operations, 59 to 60 range, and 65 plus or minus 2 years for, that doesn't really help, but plus or minus 2 years for dual pilot operations. Now, there's a new study that's going on, part of the medical provisions study group for ICAO. Susan and I were both at that meeting 2 weeks ago. And what we're trying to do is look at, is there hard science for drawing a particular age limit? Because truthfully, right now, the age limit 60, 65, wherever you draw it is an arbitrary limit. The science isn't solid enough to say that it's safe to change. And as was mentioned yesterday, we don't want to make it just as safe, we want to make it safer. So we need evidence to make rule changes that would be safer. I think those studies will come out. We also have to consider the balance of experience that adds to that versus deterioration in certain functions, some which can be measured, others which would meet standards. Examples might be hearing. We have a decline in hearing as we get older. We have more cataracts, our vision, our fatigue tolerance changes as we get older. Our circadian desynchrony challenges become greater too. And those are very, very difficult to measure, if not impossible to do. And to draw that as a specific conclusion, just because we don't have enough Part 121 pilots that we can actually do those studies and develop scientific significance to the data that we gather.
No, it's very true, yeah. There's very few of us, and while we number largely in our own brain and we all know different pilots, it's one of those things that when we are looking at the general population, we're very small subset, so it's very true. So,
A
Shifting.
superhuman subset.
Yeah, superhumans. No, but we touched on this in the panel earlier, just for a brief second, about mental health and wellness and the Germanwings 9525 accident that happened. And especially following COVID, there's been a huge push now and a spotlight shown on mental health and wellness and how do we take care of ourselves, especially, and it's significant in the aviation industry because loneliness is a very, the new epidemic is now loneliness, so that was declared by the federal surgeon. So what we would like to talk about now, or I guess, Susan, for you, is could you talk about Wellbutrin and the latest antidepressant that was issued and allowed by the FAA? You touched on it just for a brief second there. Back in May, it was approved. What's the process for that? Are you foreseeing adding other antidepressants that pilots can fly on and updating some of the newer, going to the newer medications that are allowed for anxiety and depression?
Sure. So, yeah, mental health is a huge, huge issue. And I've been on the road a fair amount talking to anybody that'll listen, that we need to start mentoring each other and listening to each other and dispelling the myths that if you're ever diagnosed or seek help, you'll never fly again. Because most of them will return to flying, not all. I still don't like schizophrenic and psychotic people in the cockpit. They make me nervous. But somebody with depression because they lost their parents, or you can also get depressed when good things happen because it's the same stress on the system, if you will. And it's a whole lot easier for me to deal with individuals if they've got mild to moderate disease than it is if they've progressed to severe or recurrent disease, because now they've got a different kind of track record. So some of the things we've done, there's now a checklist in the Guide for Aviation Medical Examiners, and if I slip and call it the AME Guide, sorry, but the Guide for Aviation Medical Examiners is the actual title. So there's a checklist in there for PTSD. There's a checklist in there for situational depression and anxiety that the AMEs can issue if everything is appropriate based on those checklists. When it comes to medication, I love my staff. They wanted to do this all as a group. So yes, we are considering other medications. And I went to them and I said, no, give me the one we can do now, the one you're most comfortable with, and that was bupropion, better known as Wellbutrin, XL, so the extended release one. We don't like the short ones. The extended release gives you a much better blood level of the medication. We have 5 others in the hopper we're considering, the SNRIs, and there's a couple others. And as those mature in the science that we have, we'll begin to add those. Constant review, constant quality improvement sort of things. The other thing we did recently, how many of us know somebody in their 20s that was an ADD or ADHD person when they were little? Or the diagnosis wasn't made by a competent medical authority with training in psychology or psychiatry or enhanced training for other specialists? The end of last month, we rolled out an ability to fast track a subset of those individuals. Now, the individual is going to have to collect a fair amount of information and going to have to get a review, but if everything is appropriate based on our checklist, the AME will be able to issue and submit that documentation to us. That's not all ADHD. It has to be more than 4 years since they had any symptoms, more than 4 years since they were treated with any medication, and no comorbid disease. So they can't have ADHD and depression and go through the new process.
Okay, great. No, I appreciate that, thank you. So Tyler, could you tell us a little bit, there's no specific list in Canada for what medications you can fly on or can't fly on. Could you talk about how you work with the pilots that are diagnosed with a mental illness? What's the process like for a pilot going through that? And what do you look at for the medications that they can be on or cannot be on?
All right, so I'm happy to report that in fact there is a list.
Ooh.
And we've published a staff instruction, so one of these modular policy documents that I'm talking about. It just came out just before the summer. So it's actually been in the hopper, and the practices have been in play actually for many years.
Okay.
But we were able to finally get the policy document polished up and approved, and it is available on our website. I regret to say that the way our websites are constructed conform with broader government policies, so they don't always, they're not always as user-friendly as we would like. They are constrained, but the staff instructions are available on the Transport Canada website. They're a little tricky to find, but they are there. So we actually do have a staff instruction on depression and antidepressant use, and the annex to that staff instruction contains a list, and I don't want to say that they are approved. What we've described them as are medications that people have successfully been certified on, and we have medications that are not generally compatible with aviation certification. So we have a list of these ones can be and have been approved, and other ones that are not compatible. So you can interpret that as you will. Canada actually was one of the first regulators about 20 years ago to enable pilots with diagnosed depression who were treated adequately and in remission and still on antidepressants to return to the cockpit. So, but much like Susan, it is a constant communication effort to let people know that if you get depression, it doesn't mean the end of your flying career. Most people, especially if they're treated early and aggressively and don't progress to recurrent or severe symptoms, they can return to the cockpit, and we do return people to the cockpit. So we do want that message to get out there. We also have another document, another staff instruction that came out this year, which is a little broader, but it is medications in aircrew. So we have a list by class. So we try not to get into listing specific types, or definitely not brand names, but we actually have a staff instruction that provides better guidance now on what medications in general are either low risk or high risk for aeromedical certification. So we are getting that out there, and we're getting that socialized amongst our medical examiners, and eventually in places like this, we can socialize it amongst the flying community that these documents exist, and they do provide that more granular detail about what kind of medications you may be able to fly with, and which ones are definitely not going to be considered compatible, but we do have a list now, so
That's
glad
great.
to report that.
Awesome. Thank you very much for that. I'm sure our Canadian pilots are happy to hear this. So, Quay, could you tell us a little bit what you have done? I know we worked long and hard when we were developing the pilot peer support course. Could you tell us what your role is within AMAS as far as supporting mental health and wellness within our pilot group? What are your interactions like with the regulators? I know Susan's been great about including both of us. It's a team effort. It truly is. So what has it been like what would you say the best thing is about helping our pilots that are going through something, and how do you inspire hope for them?
Sure. I'm very proud that I was able to participate with the Great ALPA effort to initiate peer support. We worked a long time on that, and I think it's very successful. We actively encourage people to use Carrie's there and talking about the peer support program, but also HIMSS is another great example of peer support. And just for the audience, about 80% of problems can be resolved. Mental health issues can be resolved simply by talking with a peer. And as Susan talked about earlier, she would rather see things at a lower level and get addressed and resolved than to try to deal with it when it becomes more severe. So one thing that our office does, because we're not AMEs, but we're all aerospace medicine specialists, is talk with the pilots and let them know, number one, your health is most important. Your mental health is most important, because that makes you a safer pilot, and that makes you a better parent, brother, sister, etc. And that will increase your chances for maintaining your certification and your career. For those people who perhaps exceed the level of severity that a peer can support through an escalation protocol, we look for aviation-savvy mental health providers to assist them, but again, to get them the treatment they need at the earliest possible stage. And then with increasing severity, those pilots that may have to use antidepressant medications, since we're not AMEs, we are not AMEs, they're willing to talk with us. And the fear of, if I start on medication, my career is over, can be eliminated by saying, there is a path, and we will help you through this path. We'll work with your physicians, we'll get the documentation that the FAA requires so that if you're stable on this medicine, you can return to fly here. But the most important thing is your personal health and aviation safety. If those two things are taken care of, then your career is usually taken care of as well. But I can't emphasize and thank the previous panel and all the work that they do in each of their committees, because the peer support aspects through pilot assistance is absolutely essential. It removes barriers for seeking help and is a very, very noble effort that improves the overall health of our pilot population and also aviation safety.
Absolutely, absolutely. I think one of the things, and we've talked about this, you know, you just mentioned like with the packets that are involved, and one of the big complaints we get from our pilots in Canada and the US, believe it or not, it's a joint complaint, is it takes such a long time to get our paperwork processed. So Tyler, could you tell us, is there anything that has been done to upgrade the technology within Transport Canada as far as the processing timelines, if you have a goal for what you are striving for to try to get the paperwork processed in and get a medical out to the pilots, and if there's any improvements or changes on the horizon that you could speak to? That's a lot of questions right there.
That's a lot of ground to cover, and we've only got 20 minutes. So first off, I will say that right now, so the nominal service delivery timeline for medical certificates is 40 business days, which is about 56 calendar days. There are caveats to that. So basically, if you look into it, really it applies to ab initio, so new applicants that are medically uncomplicated and whose applications are complete. So where the medical examiner hasn't forgotten to include something important. So those ones, that's really the group of files that the 40 business day service delivery timeline applies to. And we are meeting that. We had some blips over COVID where we were having some challenges meeting that because we had some loss of staff that we had difficulty reconstituting in the context of COVID. We never shut our doors. We never had any downtime. There was never a strategic pause. There was never any loss of productivity from people working from home. Like none of that. That has been circulated as a possibility. None of that is actually true. It had to do with inability to regenerate staff. But actually, since last year, we have been meeting that service delivery timeline. So that doesn't apply to most people in the room here. That will apply to those new folks, that new surge of new applicants that we're seeing that Susan alluded to. We're seeing similar phenomenon in Canada as well. But what remains then, anything that's medically complex that can't be renewed by the medical examiner in the field. And 75% of all files are being renewed immediately in the field. 17% are the ab initios, and then we have this other grouping, less than 10%, which are medically complex. And that's the group that actually takes most of the time and resources within our group. And the amount of time that it takes to process a medical file really corresponds to the complexity. It correlates to the complexity. One of the things that I should point out is that we, much like the FAA, we have to interact with the broader medical community. We have to ask for tests and people to go back and see physicians or specialists in the general medical system. And regulatory medicine is, let's face it, it's deprioritized compared to direct patient care. So somebody who needs treatment for cancer is going to see the specialist before somebody who needs it for, pilot licensure. And that's probably, I think everybody agrees that that is the right thing to do, but there's very little influence that we have over that. So that can be a rate limiting step. We have limited resources as well. We have, 31 permanent staff and about 20 part-time staff to manage 60,000 files a year. We're about 10 times smaller than the FAA, so you can add a zero to that, and that would kind of be the equivalent in American dollars. So these are things that slow down the process. And some of these are dependencies that we don't have any control over. That said, there are things within our department that we can control and that we are working on. So some of the changes that we've made, so first of all, those policy pieces, those are really vital so that we can make sure that medical examiners in the field are gathering the information, they have the tools and they know what's needed so they can step off early and get that information gathered, and so that the pilots know what information is going to be needed. That expedites the process. The other thing, the big thing that we've done in the past 3 years was digitize. So we moved from paper-based processes, paper-based applications, to digital applications, online processes. One of the silver linings of COVID is that it was a catalyst for this digital transformation. So something that we thought was going to take 5 to 10 years, we were able to do it within 3 years. So that was a big victory. And we've taken all of the legacy files that are on paper, and they are currently in Montreal in a warehouse getting digitized. So 5 million pages of legacy documents are all being turned into ones and zeros, which is enabling us now to move these files around the country to the people that need to see them or where we have capacity, because our teams are distributed across the country. Rather than having a file in Ottawa that can only be seen by staff in Ottawa and where we're rate limited by capacity in Ottawa, we can now digitally shift that and reassign it anywhere in the country to maximize our efficiency. We're also in the midst right now of launching an online applicant portal, which will eliminate letter mail. So instead of the lag of sending requirement letters out by mail and waiting for things to come back by mail, it's going to be a portal. So you can do, it's like Amazon package tracking. You're going to be able to go on, get some rudimentary information about where your application is at. It's not as good as Amazon. We're not quite there yet. But you can see where your application is in terms of its processing stage. And if you have a letter that we need to send to you, we're going to upload it there for you so you can pull that information. And we tried this with another service. We tried this with Canada Post Connect, which was a service, basically an email-based service, which allowed confidential medical information to be transmitted, specifically made for government. It was great 3 years ago. It's not so great now with the proliferation of spam. People don't want to click on links they don't recognize. So that's not working anymore. So we needed to build a portal where people felt confident. So in the same way that you pay your taxes to Revenue Canada, through a portal, you can go to the Transport Canada portal and be confident that this is a real site. So these are things that we've done to move this forward, and we've hired a bunch of new doctors and admin staff to increase our capacity. So that's what we've done, and we continue to build on that. We've always got work and improvement to do, but I think we've moved the ball down the field significantly in the past couple of years.
Great. Now, I'm going to shift gears just a little bit, because one of the changes that was made within the FAA is that the HIMSS AMEs are now able to upload digital documents and digital packages to the FAA directly and get a receipt. Now, I don't want to focus so much on that, Dr. or Susan, but what could you tell me about the HIMSS program and the lifetime monitoring? Because you did receive a lot of input from the HIMSS chairs, a lot. And Craig, thank you for that. And no, but there were a lot of changes that were made to the program itself for the lifetime monitoring. Could you talk just briefly about what those changes are? Do you see any more coming down the road for the HIMSS program? And then we'll open it up for the questions from the audience. So.
Sure. Essentially, based on some recommendations out of the NTSB, we ended up in the lifetime monitoring arena with the assumption that the issue is something that an individual fights for their lifetime, right? And it caught many people unawares because they were expecting to be turned loose at 3 or 5 years, and that changed. There is a process that I have not been briefed on yet, but I should be in the very near future, that will modify the level required. I don't have details, but watch this space and more is coming. Okay. Can I make a comment on something that
absolutely.
Tyler said earlier?
Absolutely.
So how many of you know that the AMEs can direct upload documents? Let me rephrase that. The AME of record can direct upload documents into your files. There's a couple of you. As of April this year, They can upload up to 25 documents per exam or application. They have to be 3 megabytes or smaller. And what that's done for us is allow us to stop this letters crossing in the mail. Because we were at a point about a year ago where my LIEs, legal instrument examiners, were getting to deferred medicals within 2 weeks, but my scanning was at 27 days. So if you had sent it in, now I'm asking for the same stuff you sent in and everybody's upset. And there's a long story to how that happened, but I'm now down to 4 days for backlog and scanning. And a big reason for that is more than half of my AMEs are using the direct upload feature for 12,500 pilots so far. And it's stopping that crossing in the mail bit. Now, a couple other things I would advise you to consider doing. How many of you have seen any of my pilot minutes? They are micro-learning events, 60 to 90 seconds. There's 17 of them out right now. The very first one was how to expedite your medical. If you don't use a service like AMAS and you send us everything, please read it before you send it, because we will. And if there's an inaccuracy in that, we're going to ask questions. And every time I send a letter, your exam, your package is going to be delayed, I think, at least a month. So read it. If you can't read it, or it's not signed or dated, get it done before you send it to us. If there are inaccuracies, get them corrected. If you can't interpret the doctor's writing or the jargon, go to somebody like Quay. Help yourself on some of this. We are not as far along as a portal. That should happen in the next couple of years. Our cybersecurity people are very powerful, shall we say. And setting up the double authentication in our existing systems has been a bit of a challenge. We are working to get Quay and his bunch the ability to send us documents digitally too, but they're not AMEs, so I can't put them through that process because they can't be your AME of record.
Okay, well with that question, we have been officially cut off from our time. So we do appreciate all of it. The doctors will all be around in the common area throughout the night. So we do appreciate your time and involvement. And I'd like to thank our panelists very much. So.